Welcome everyone to the Natsal-COVID study webinar. Thank you so much for joining us. The announcement of a UK national lockdown on 23rd of March found everyone in different circumstances. Some were looking for a new sex partner, others in a long-term relationship, others on the verge of breaking up. Some had STI symptoms they thought they should get checked out, while others were about to start fertility treatment. The months that followed were unprecedented for sexual behaviour mixing and disruption to services. Many of you listening will have been involved in the enormous efforts to reconfigure services and help out with the COVID contact tracing. This national COVID study is our contribution to that effort. We aim to add an understanding of what might have happened at the population level to support other clinic-based studies and routine surveillance. We've got a lot of data to show you, and we hope that it will be helpful in planning at a national level for recovery in sexual and reproductive health. I really like this slide from the Information is Beautiful website, which shows the risk of COVID from a wide range of social activities. But when I saw it, I did think, where is sex on this slide? We know it's risky for COVID, and it's far more everyday than many of the things here, like going to a casino or a museum. I think this is just one of the examples of how sex gets forgotten in the dialogue around the pandemic, and for us, one of the reasons why we felt it was important to do the Natsal-COVID study. Before I hand on to Nigel to tell us about the methods, I wanted to just briefly put the period of reporting and data collection for the study alongside the timeline for COVID-19 social restrictions across the UK. So almost all of us remember March the 23rd when we were asked to stay indoors and only leave the house for exercise once a day and essential provisions. Life was like that until the middle of May, when we were first allowed to meet with others outside the household, but to stay 2 metres apart and to be outside. Over the coming months, things very gradually eased, but it wasn't until early July that the 5-mile travel limit was lifted in Scotland and that pubs, restaurants and hotels began to open with strict social distancing measures. Our period of reporting covers the 23rd of March to the point at which participants filled in the questionnaire somewhere between the end of July and the 10th of August. So this just gives you a little bit of a sense of what was going on over that time. Mostly it was a period of tight lockdown with some very minor easing, and then towards the end, the last 4 weeks before data collection, people were allowed to move a little bit more freely.
Following on from what Kirsty has said, I know that you'll be very keen to start seeing the results of the study. But allow me just 5 minutes to take you through the study objectives and some of the key methods that will underpin the rest of the presentation. The objectives of the Natsal-COVID study were to rapidly understand how sexual and reproductive health in Britain has been affected by the pandemic, with a particular focus on the 4 months from the start of the national lockdown in March 2020. And in this presentation of preliminary data, we've focused on the following objectives: to understand sexual activities and behaviours, relationship and sexual difficulties, and sexual and reproductive health service use and uptake of interventions. There's also a section in the slides which explores how compliance with physical distancing has been affected by sexual intimacy needs at a population level. And overall, our aim is to disseminate the data and hear your thoughts to inform the service design of sexual and reproductive health services and the provision of these services both during and after the COVID pandemic. Natsal-COVID is very different to what you may be used to if you're familiar with the decennial Natsal study. Rather than being a probability-based sample, it's based on an online panel which uses quota sampling, and this has been done in collaboration with Ipsos MORI. The sample was aged 18 to 59 and we had a boost of 500 young people. The quotas were based on age, gender, region and social grade and used ONS census data and then the mid-year estimates to arrive at a sample which aimed to be generalisable to the general population. The questionnaire was run online from the 29th of July to the 10th of August, and on average, participants took 10 minutes to complete the questionnaire. Ipsos MORI has a number of quality controls to ensure the quality of the data, and the data that you'll see presented are weighted to ensure that the weighted profile of participants matches the target quotas. This slide shows the outcome of the Natsal-COVID recruitment process. In total, 17,425, the number at the bottom, applicants were approached to take part in the study, and 6,657 people completed the study. This is different to a response rate, however, because many of those approached were in quota that were already full. So 8,873 were part of quotas that needed no more cases. The questionnaire design was based on previous Natsal studies and included demographics, health, sexual history and partners, sexual and romantic lives during the pandemic, porn use, sexual function, sexual and reproductive health service use, and access to services, contraception, relationships, and difficulties. Although we're not presenting the data today because the analysis is still underway, we've completed follow-up interviews with 45 participants who completed the questionnaire. And these were telephone and video interviews with individuals who reported one of the following: either that they'd had a sexual or romantic contact with someone from a different household, or that they needed but had been unable to access sexual or reproductive health services, or that they'd experienced relationship challenges during lockdown. And we hope that these qualitative findings will enhance the quantitative findings, and we look forward to presenting them in the future. This slide summarises the approach taken by the Natsal-COVID study towards gender. And this approach was inclusive and included response options and questionnaire routing in line with organisations like the Office for National Statistics. Here and throughout we use trans as an umbrella term to include all gender minorities. And at the beginning of the questionnaire, 2 questions which you can see on the slide were asked about gender to all participants. In total there were 61 trans participants, and in the slides of data that follow we present data for all participants and for men and women, depending on the questions being answered, and at all times including trans participants. You'll see as we walk through the data in the slides that follow that the denominator changes depending on the question we're interested in. And this slide shows 3 of the key denominator groups, so that all individuals, the full 6,654 people who completed the questionnaire, sexually experienced people, which means people who had at least one sexual partner of any gender in their lifetime, and sexually active individuals, and that means at least one sexual partner of any gender in the past year. And these groups are broadly similar, but importantly different in their steady relationship status. So in particular, the group that's sexually active had far fewer, only 26%, who are currently in a steady relationship. We've also compared the Natsal-COVID sample to probability surveys asking similar questions, and we used the annual population survey from 2019 and the Health Survey for England from 2018 to do this. As you'll see in a moment, the distributions were generally similar for ethnicity and urban or rural status, but there were some very striking differences which were important for interpretation. And these were a lower proportion in the Natsal-COVID sample with married status, and higher proportions in Natsal-COVID reporting to be either non-heterosexual, in poor health, or with higher education status. So just to walk you through these data, these are the ethnicity data and rurality data for Natsal-COVID compared to APS and HSE respectively, and in both cases they're broadly similar. Whereas we see more people in Natsal-COVID who are not married, and more people in Natsal-COVID who had a degree education, and fewer who had no qualification. General health status was also different, so there were fewer people in very good health status and more people in fair health status in the Natsal-COVID sample, and more people with a limiting illness or disability. Sexual identity was also different, and it was noticeable that there were more people in Natsal-COVID who were from a non-heterosexual identity. And this focuses on the top 80% of this graph, highlighting that there were, particularly in men, more people who reported being gay or lesbian, more men who were bisexual, and fewer who said that they preferred not to say. So what does this all mean as you watch the results over the next slides? Well, there are some important strengths of Natsal-COVID. It's a large and national sample, and there are very few missing data, but it's not a probability sample in the same way as the Natsal decennial study, and it's therefore not possible to say that it's truly representative of the general population. Natsal-COVID was undertaken extremely rapidly, but we used a questionnaire design and an approach that's been developed by the Natsal team over many years to ask about highly sensitive behaviours and experiences, and we feel that we've achieved the best quality possible under the circumstances where the gold standard probability sampling and face-to-face interviews haven't been feasible. So although there are important known and also likely unknown biases in the sample, which means some caution's needed in interpreting the results, we feel that the findings are likely to be broadly generalisable, even if the prevalence estimates in particular should be treated with caution.
This presentation focuses on sexual behaviour in Britain since lockdown. Specifically, who's doing what, how often, if and how this has changed in comparison to the months prior to lockdown, and how people feel about the impact that lockdown has had on their sex lives. First of all, let's look at the sexual history of the Natsal-COVID sample and how this compares to what was observed for those of the same age, 18 to 59, in Natsal-3, given that Natsal-3 was designed to be nationally representative, and although it's around a decade old now, it's worth remembering that few changes in sexual behaviour were observed between the last 2 rounds of Natsal. So the first thing to note in terms of sexual history is that a much smaller proportion of the Natsal-COVID sample reported ever having had sex. However, men in Natsal-COVID were more likely to report having had same-sex experience, which tallies with the relatively large proportion of men in the Natsal-COVID sample who identified as gay or bisexual, as Nigel described. If we focus on those who did report sexual experience, then we see similar distributions of partner numbers for the lifetime across the 2 samples, as you can see from this chart. This is also the case for the distribution of partner numbers in the last year, when we focus on those sexually active. However, looking more recently, and as we might expect given COVID and lockdown, we see that sexually active participants in Natsal-COVID were less likely to have reported new partners in the last 4 weeks, at 4%, in contrast to the 8% observed in Natsal-3. And looking just at the Natsal-COVID data now, and in the 4 months since the start of lockdown, just 5% of those sexually active reported new partners since the start of lockdown, while 4% reported specifically new condomless sex partners, so around 80% of those reporting new partners since the start of lockdown. So turning now to what people in Britain were doing sexually since lockdown, and the survey asked about these 10 behaviours, half of which we can think of as physical behaviours, including but not limited to those with someone else. So kissing through to vaginal, oral and anal sex, as well as mutual and solo masturbation. Similarly, some of the what we termed virtual behaviours may or may not have involved someone else, e.g. looking at pornography. Because many of the behaviours do involve someone else, it's important to not just consider what the population as a whole was doing, but how this varies by relationship status. And so we stratify our analysis according to 4 broad relationship status groups. These are those not in a steady relationship and who reported no partnered sex since lockdown, abbreviated in the upcoming charts to no partner contact, which accounts for 1/4 of the Natsal-COVID sample. There are also those not in a steady relationship but who'd had sex with someone since lockdown, abbreviated to casual, and accounting for 11% of the sample. Then there are those in a steady relationship but who weren't living together, abbreviated to steady non-cohab, accounting for the smallest proportion of the Natsal-COVID sample at 7%. And those in a steady relationship and who were living together, abbreviated to cohabiting, which accounts for over half of the sample. So first, in terms of physical behaviours. Overall, 86% of all Natsal-COVID participants reported at least one of the physical behaviours asked about since lockdown, including around half or so of those in the no partner contact group. Furthermore, the proportion was similar, in excess of 90%, among everyone else, so little difference according to whether or not this was a steady relationship, nor if participants were cohabiting or not, which is perhaps surprising, as the question was about behaviour since lockdown, although, as acknowledged, the survey period coincided with lockdown rules being relaxed. Focusing now specifically on the reporting of vaginal, oral or anal sex since lockdown, and 83% did so, with this proportion highest at 90% among those having casual sex. And in terms of frequency of partnered sex, there was little difference by relationship status, with around 30% reporting this at least several times a week since lockdown. Masturbation was reported by 58% of people overall, but those having casual sex were again most likely to report this at 77%, while those who'd had no partner contact were as likely as those who were cohabiting to do so. However, of those who did, there were few substantive differences by relationship status in frequency, with around 2/3 to 3/4 reporting masturbation at least once a week, the hash bars here. Finally in this section, a comment on the use of sex toys, as there have been claims of a surge in the sale of sex toys since lockdown. In Natsal-COVID, we found that around a quarter reported doing so, with a similar pattern with relationship status to that we observed for masturbation. That is, those having casual sex being most likely to report sex toy use since lockdown, at 46%, in contrast to just 11% of those with no partner contact. Looking now at virtual behaviours, and as you can see, these were less commonly reported than physical behaviours, with around half of people doing so since lockdown, but with porn use really driving this at 44% of the sample, while less than a quarter reported the other virtual behaviours we asked about. As we observed with masturbation and sex toy use, porn use was again highest among those having casual sex at 67%, and declined with the relationship formality, but still 40% of those cohabiting reported porn use, which is similar to the proportion of those with no partner contact since lockdown. In terms of frequency, this declined with increasing relationship formality, from half of those with no partner contact reporting porn at least several times a week to around 1/3 of those cohabiting. Looking now at changes in sexual behaviour since lockdown, we asked, compared to the months before lockdown, have you done these things more or less since lockdown? Around half of the Natsal-COVID sample reported no change in these physical sexual behaviours, denoted by the crosses in the coming charts. But where change was perceived to have occurred, then this was more likely to be a decline in frequency, and typically the proportion reporting a decline was twice as likely as the proportion reporting an increase for partnered physical behaviours. As might be expected in terms of the opportunity to have partnered sex, reporting no change in vaginal, oral or anal sex, again shown by the crosses here, was twice as likely among those cohabiting than those in casual or steady non-cohabiting relationships, with those not living with a partner far more likely to report a decline in vaginal, oral or anal sex than an increase in frequency since lockdown. The opposite pattern was observed for masturbation, with those perceiving a change more likely to report this being an increase overall and by relationship status. Reporting an increase was most common among those not living with a partner, so the opposite pattern to that observed for partnered physical behaviour. In terms of changes in virtual behaviours, and it's a bit of a mixed picture in terms of the amount and direction of change, except for porn use. Overall, 59% reported no change. Again, the crosses here. But of those who did, almost twice as many said that their frequency of porn use had increased since lockdown, a pattern evident across relationship status groups. In terms of age group differences in the reporting of changes in sexual behaviour since lockdown, and the direction of those changes, and younger people were more likely than older people to report a change in the amount of partnered physical behaviour overall. And somewhat within each relationship status group, with the proportion reporting an increase being higher at younger ages. But these people were in the minority, as people were more likely to say that they'd had less sex since lockdown, regardless of age or relationship status group. So how do people in Britain perceive these changes? As we might expect, it's another mixed picture. Around 1/3 of people reporting changes in their sex life didn't view them as either positive or negative, the orange bars here, perhaps considering them just part of life. However, similar proportions, around a quarter, viewed the changes as either positive, in blue, or negative, in grey, while 13% said that they had mixed feelings, the yellow bar. Given the differences observed in sexual behaviour since lockdown by relationship status, it's not surprising that differences exist by relationship status in how people felt about these changes. Of note, the proportion describing the changes as mostly negative being greatest for those with no partner contact at 38%, reducing to 20% of those cohabiting. And this is evident from this forest plot of the crude odds ratios of reporting changes in one's sex life since lockdown, and for these to be perceived as mostly negative. And the chart shows that these were felt more acutely by those not living with a partner, as we've just seen, by younger people, and more by men than women. And as shown by the forest plot here on the right, associations that remain in multivariable analysis, so taking account of all three of these variables at the same time. So in summary, at a population level, most people in Britain have had sex of some kind since lockdown, and around half are unlikely to consider this to have changed in frequency in comparison to the 3 months before lockdown. However, for those not living with a partner, then changes were far more likely to have been reported, with partnered sexual behaviour declining in frequency, and behaviours not necessarily requiring a partner increasing in frequency since lockdown. It's not a clear picture, though, with differences in these changes and how people feel about them existing according to relationship status and to some extent gender and age group, with interactions likely to be at play, which we are now exploring. So what are the implications of these findings? For many people in Britain, their sexual lifestyles and therefore their sexual health needs seem to have been unaffected by lockdown. This does mean, therefore, that there continues to be a minority having casual sex, new partners, and specifically new condomless sex partners, for whom access to sexual and reproductive health services is necessary, even if they perceive that the amount of sex they're having to have decreased since lockdown. While engaging in sexual behaviours not requiring partners has increased, maybe providing an alternative to partnered sex for some, for many, the lack of a sex life during lockdown may well exacerbate feelings of isolation, loneliness, and poor mental health more broadly. Sexual behaviour is part and parcel of an individual's health and well-being and needs to be recognised as such. Alongside the intersectionality of the factors examined here, other factors associated with sexual behaviour, such as sexual identity and ethnicity, as well as lockdown-specific factors, such as geography. For example, in terms of the opportunity people had during lockdown to meet partners in their locality.
Hi, I'm Pam Sonnenberg, and this presentation is going to be looking at the Natsal-COVID study in a slightly different way. Whereas the other presentations looked at the impact of the COVID-19 pandemic on sexual behavior or service use or relationships, here we're going to be looking at the impact of sexual behavior on COVID-19 transmission, and specifically the effect of sexual intimacy needs on adherence to physical distancing to prevent COVID-19 transmission. So mathematical models and public health messages of non-pharmaceutical interventions to prevent COVID-19 transmission are based on underlying parameters of population mixing and assumptions of compliance. So at a population level, it's important to know the extent that sexual intimacy needs affect adherence to physical distancing measures. Key groups for potential COVID-19 transmission are individuals who meet romantic or sexual partners who live outside their household and do not maintain physical distancing. So our aims were to explore how compliance with physical distancing has been affected by sexual intimacy needs at a population level, and to identify factors associated with having physical contact with a romantic or sexual partner outside the household. It's important to note that the denominator is the total population, rather than only those who sexually experienced or sexually active, as this is the key parameter for modelling population impacts. So we designed a set of questions on sexual romantic partners in the 4 weeks prior to interview and whether they were living in the same household or not. It's important to see the study in the context of the COVID-19 pandemic and particularly the interventions that were occurring within the UK. Just to note that the Natsal-COVID fieldwork was from the 29th of July to the 10th of August. So any questions that we asked in the 4 weeks prior to that would be from the end of June into early July. And that's quite important because on June the 19th, the alert level downgraded from 4 to 3. But very specifically, there was a change in guidance from on the 10th of June, in which there was the creation of so-called support bubbles, which says in England, if you live by yourself or you are a single parent with dependent children, in other words, there's only one adult in your home, you can then expand your network so that it includes one other household of any size. So these support bubbles meant that people would then be able to meet indoors or out, less than 2 meters apart, and stay overnight as if they were with members of their own household. So for the study, we had a number of questions on romantic sexual experiences in and outside the household. And there were a few very specific to this analysis. So firstly, as I mentioned before, that they are questions about romantic or sexual experiences in the last 4 weeks. And the first question asked whether people were living in the same household, not living in the same household, but in the same bubble, or not living in the same household, not in the same bubble. And very importantly, there was an option that people could click on where a support bubble was defined. We then went on to a question saying, thinking about that person or those people in the last 4 weeks, which of the following did you do with them? And it specifically again says, think about the things when you were not living with this person. And then there was an option to select a number of options here. We then defined the outcome for the study as reported physical contact with a romantic sexual partner, and that was anyone who had ticked at least one of the following, from holding hands, kissing, oral, vaginal, or anal sex, or any other contact with the genital area. So overall, just over 10% of participants reported physical contact with a romantic or sexual partner who lived outside their household in the previous 4 weeks. But what was interesting is that in all age groups, there was a higher proportion who reported contact within a bubble than outside a household as well as outside a bubble. And this was highest in the 18 to 24-year age group, but then reduced with age. So when we looked at this, it made us question the responses that people were giving to the question about being in a household, being in a bubble or not. So we're very fortunate to have a nice paper led by Ty Curtis using the Natsal-COVID data. So that's the British Probability Sample Survey from 2010, and that looks at the household structure. And what this shows is that particularly in young people, very few people live alone. And so that's the red areas in these two figures. And so only those in the red area or the smaller proportion in the green area who would live with children or grandchildren, not with a partner, would be the ones who would actually be able to have met those criteria to have been in a bubble. So at least one of the partners would have had to be in this group. We therefore felt that all further analysis should combine those who said they'd had a partner within a bubble or outside a bubble. So as mentioned earlier, just over 10% of our participants aged 18 to 59 reported physical contact with someone who lives outside their household in the previous 4 weeks. So when we look at the type of contact that people had, the large majority, 86%, reported having had oral, anal, vaginal sex or genital contact. 10% reported kissing, and 4% of only holding hands, hugging or cuddling. This slide shows how people reporting physical contact varied by age and by gender. Younger people were more likely to report physical contact outside their household than those who were older, and in fact 20% compared to about 10% overall. It was also higher in men 25 and older than in women. This slide now shows the factors associated with physical contact outside of their household. As shown in the previous slide, there's the strong association with age, with older people being less likely to report contact outside their household in both men and women. The age-adjusted odds ratios also show that those who reported a heterosexual sexual identity were less likely to report contact outside the household than those who were reported being gay or bisexual. And after adjusting for age, there was still a finding that those in bad or very bad health were less likely to have physical contact with someone outside of their household. In the subgroup of participants who reported physical contact outside a bubble and outside their household, and that was 418, we asked a supplementary question which asked about contact in the time since lockdown started in March, and found that nearly 50% of those people also reported having had physical contact outside their bubble and outside their household during that period. So in summary, over 1 in 10 participants aged 18 to 59 reported physical contact with a romantic or sexual partner outside their household in the 4 weeks prior to interview. And also of those we asked, half also reported similar contact in the stricter lockdown period. higher proportions in younger people and people who do not identify as heterosexual, which may also reflect the differences in household structure. Most contact included sex or genital contact, but we must remember that kissing is also a high COVID risk activity. And one of the key lessons learned is that questionnaire design is difficult in a rapidly evolving pandemic as interventions, behavior, and terminology change. So what are the implications for research, policy, and practice? Mathematical models of the impact of physical distancing interventions to reduce COVID-19 transmission need to include household structure, age-specific meeting patterns, and physical contact for romantic or sexual reasons. It's important to understand the context for meeting partners outside the household, and we're currently analyzing data from qualitative interviews in a subgroup of these participants. The age patterns of outside household mixing for romantic or sexual reasons may contribute to the recent trends showing increased COVID-19 infection in young people. And importantly, public health messaging may be confusing and have unintended consequences, such as the creation of support bubbles, which then give reason for people to mix more broadly. So maybe we need to have more clear public health messages when in lockdown, no physical sexual contact outside the household. So hands may mean don't hold hands. Face may mean no kisses, or we might be on the Titanic. And that there are no sexual positions that don't involve some COVID-19 risk. Thank you very much.
Hello everyone, my name is Kirsten Mitchell from the University of Glasgow, and I'm going to be telling you about our data on steady relationships, focusing on relationship quality, sex life and sexual problems. In the slides that follow, I'll be asking what effect the COVID lockdown had on the relational quality of steady relationships. I'll talk a little bit about the factors associated with those who reported deteriorating relational well-being. Then I'll move on to focus specifically on the sexual aspects of steady relationships and whether or not those were perceived to change. And again, focusing in on decreasing frequency and the factors associated with reporting that. And finally, I'll end by talking about sexual difficulties. Briefly then, this slide shows a breakdown of the relationship status of our participants. You can see from the green segment that 64% of the sample were in steady relationships, and by that I mean they were either currently married, in a civil partnership or a steady relationship regardless of whether or not they were living together. So the slides that follow will focus on this group of 4,271 participants. But before we move on to focus on those, I'd also draw your attention to the 2.4% of our sample who reported that their relationship dissolved during the period of reporting, and also the 0.5% who said that they started a new steady relationship in this time. Of course, we can't relate those changes directly to the impact of the pandemic, but I think it's interesting to show that those shifts in relationship status did occur. A quick summary then of the demographic breakdown of the participants in steady relationships. We had 47% men and 53% women, and as earlier indicated, that includes trans men and women because the numbers here were too small to present separately. As you'd expect, we saw a smaller proportion in the youngest age group, 18 to 24, and I'd also highlight here that 80% were employed and 89% were living together versus 11% living separately. We asked participants to think carefully about their relationships since lockdown, read a series of statements and tell us to what extent they agreed or disagreed. So these were: I feel supported by my partner and I regularly argue, I feel a strong connection with my partner, I can confide in my partner about virtually anything, I'm worried that our relationship might end, and I feel happy with my relationship. So having responded, we then asked them to compare the months before lockdown and tell us whether they felt any of these aspects of their relationship had changed. This slide shows the overall change in relationship quality compared to pre-lockdown. And just to highlight a few things here, the first is that the vast majority of people actually reported no change from pre to post-lockdown. Among those who did, it was more common to report an improvement than to report that things got worse. And this is particularly so for feeling supported by a partner and connected to a partner. If we look at those who reported things did get worse, arguments and worry about a relationship ending were more common than the other aspects of relationship quality. Overall, though, this slide paints a fairly positive picture that in the months following lockdown, there was a net overall gain in relationship quality. And that may tie in with anecdotal reports some of you may have heard about fewer distractions and more time for couples to spend together. Here we focus in on those reporting change, broken down by age group. The overall picture is one of more change in the younger relationships and greater stability in the older ones. And although I spoke of an overall net gain for relationship quality, it's important that we don't overlook these red bars, the proportion for whom things got worse. These red bars are particularly high for those reporting arguments with a partner and worry about the relationship ending. We can see that more than 1 in 5 in the youngest age groups and over 10% in those aged 35 to 44 reported both arguments and worry. And at a population level, that equates to a great many people. We then created 2 sets of summary scores for each participant. The first to sum their quality across the 6 aspects I've just discussed, and the second to reflect a summed score of change. For the first one, if the participant had a score of less than 17, they were categorised as weak, and equal or greater than 17 as strong on their relationship since lockdown. And for the second one, they were either categorised as overall improved, overall no change, or overall deteriorated, and that gave rise to 6 categories. As a footnote, I should say that I recognise this is rather arbitrary to divide relationships into weak and strong, and that most people were somewhere across the continuum. We can then look at how common each category is within the population. So imagine we took 100 people aged 18 to 59. We would find that 77 were in strong relationships in the period following lockdown, and for 47 of those people, things hadn't really changed compared with pre-lockdown. So those are the people in light green. For 26 people, they were also in strong relationships since lockdown, and actually these had got better compared with pre-lockdown, and that's the people in dark green. The 4 people in blue were also in strong relationships, but things had actually got worse when they compared it to pre-lockdown time. And then we have 23 people in weaker relationships. Of these, 5 actually said that although things were still not great, they had actually improved compared with pre-lockdown. For 11 people, things were no different really and still not great. And then for 7 of 100 people, they were in currently weak relationships and things that got even worse compared with pre-lockdown. Pausing briefly on the 7% or 1 in 14 people, data from other studies have shown an increase in domestic violence, and this was highlighted in a recent Home Office report. We did agonise over whether to include a question on intimate partner violence, eventually deciding not to for ethical reasons, since we couldn't guarantee the safety of anyone reporting this. So although we can't comment on this directly in our data, I think it's important to bear in mind that the 1 in 14 likely includes some who experienced an escalation in violence, abuse, and coercive control. Here we see the factors associated with being in a weak relationship that have deteriorated since lockdown, and we look at women first. We're also going to focus just on the significant factors. So first of all, having a degree appears to be protective, so women who had a degree were less likely to be in this group. On the other hand, not living together with a partner was increased the odds of being in this group, and you might expect that given the additional challenges of trying to maintain a steady relationship when you're not living in the same household. We found that a number of health factors were associated, so in particular receiving a COVID letter saying that you were at higher risk of COVID and should shield, reporting severe anxiety and severe depression. As we might expect, a decreased interest in sex and reporting sexual difficulties were also significantly associated. Turning to men who were in a weak relationship and reported deterioration over lockdown, we see a number of similarities and a number of differences. Like women, having a degree was protective, so men with a degree were less likely to be in this group. However, differently to women, cohabitation did not seem to be associated, so was perhaps less important for men in their relationship quality. Again, similarly to women, receiving a COVID letter, reporting severe anxiety and severe depression were all significantly associated. And unlike women, reporting less alcohol use or compared with increased alcohol use was a protective factor. And again, as with women, decreased interest in sex and reporting sexual difficulties very often or always were significantly associated with being in this group. Turning now to the sexual aspects of steady relationships, we asked participants to compare the months before lockdown and think about whether any of these things had changed since lockdown. Their frequency of sex, pleasure in sex, their interest in having sex, distress or worry about their sex life overall, and their sexual satisfaction. As with the relational quality of relationships, we found that the majority of people reported no change in the sexual aspects of their steady relationship. And we focus in here on this slide on those who did report change. This time we see a net decrease in the sexual quality of relationships. In particular, a quarter of people said they felt less interested in sex, and 28% said they had sex less often, and that might actually run counter to many people's assumptions of what happened during the lockdown period. There is some good news here, though, which is that more people reported an increase in pleasurable sex than reported that this got worse. So we looked at the factors associated with reporting less sex since lockdown in steady relationships. Many of these factors were the same for women and men. These included not living together, and that makes a lot of sense, deteriorating relationship quality, and also, as you'd expect, sexual difficulties and deterioration in other aspects of sexual quality, like less interest in sex, less pleasure in sex, and decreasing sexual satisfaction. Both anxiety and depression were associated with decreasing frequency, and disability and poor health in men, but not women. In terms of other things that were different, these included Asian British ethnicity in women, but not men, and reporting a gay sexual identity in men, but not women. Finally, we asked about sexual difficulties. And by this we mean things like anxiety, pain, vaginal dryness, difficulty getting an erection, difficulty reaching climax, or reaching climax too soon. We first asked participants if they'd experienced any sexual difficulties since the start of lockdown. If they said very often or always, we asked them which difficulties they experienced. If they said never, not very often, or sometimes, we then filtered them to a question which asked, compared to the months before lockdown, did you experience sexual difficulties more or less? And I'll report the data very quickly from these questions. As before, most women and men reported no change. However, 17% of women and 16% of men said that they'd either experienced more difficulties or that new ones had begun since lockdown. And that's compared with only 8% who said things had actually got better. That is, they had fewer sexual difficulties than before. Focusing in then on those who reported an increase in or new sexual difficulties here by age and gender, we see among women a fairly steady decline across the age categories and slightly less clear pattern for men. I draw your attention here to the proportions themselves, and they're really quite high, well over 20% and between 15 and 20% in the younger age categories for women, and just under 20% for men. And on a population level, again, that's a large minority of people who encountered more sexual difficulties or new ones post the initial lockdown period. Of those experiencing problems often or always, we asked them about the different difficulties they experienced. I draw your attention to the small sample size here, so we need to treat these data with caution, and also just to note that people were able to tick more than one problem. Roughly, the proportions look fairly similar across the problems for women, apart from reaching climax too quickly. For men, anxiety looked slightly more common and physical pain slightly less common than the others, and most of the other problems were around the 30% prevalence mark. Of course, if we disaggregate them again by age, we see quite clear patterns, and the usual patterns that we would see outside of a COVID era, for instance, erectile difficulties being more common among older age and anxiety being more common among younger women. But unfortunately, the numbers are really too small to show meaningful differences by age group. So that's us come to the end of the section on steady relationships, and thanks for bearing with me this far. To recap really quickly, we had 64% of our sample in steady relationships, with 2.4% in steady relationship that dissolved in the period following lockdown, and 0.5% starting a new one. So focusing on this 64%, we found that across 6 aspects of relationship quality, most people reported no change. And where change occurred, there was actually a net gain for relationship quality. That's the good news of this presentation. That's more people reporting things that had improved than deteriorated. However, 1 in 14 people were in a relationship that was weak in the 4 months since lockdown and had deteriorated compared with pre-lockdown. Having poor mental and physical health, reporting a decreased quality of sex life, having had less education, living apart from your partner for women only, increased alcohol use for men only, was associated with being one of these 1 in 14 people. Across the 5 aspects of sex life, again, most people reported no change. And where change occurred, this time there was a net deterioration, particularly in frequency and interest in sex. The factors associated with decreasing frequency were not living together, no increase in alcohol consumption, poor mental and physical health again, and reporting sexual difficulties and a decrease in quality of sex life. Finally, we found that most people again reported no change in sexual difficulties. But where changes were reported, there were more people reporting new or increasing difficulties than reporting improvement.
This is the final section of data before we take questions, and I'm going to focus on the uptake of sexual and reproductive health services in Britain in the period since lockdown. Given the changes in both directions in sexual behaviours that Kath has described, in terms of both increased and reduced risk of STIs and unwanted pregnancy, and restrictions on people's movements and interactions brought about by the pandemic and the necessary interventions, as well as very rapid changes which were needed to sexual and reproductive health services in Britain in response to the pandemic, in Natsal-COVID we wanted to understand at a population level what the need was during this period for sexual and reproductive health services and how that differed between different groups within the population. We also want to understand evidence for any unmet needs for sexual and reproductive health services and which groups were at greatest risk of having unmet needs. And we also wanted to understand about how people have accessed sexual and reproductive health services during this period. The slides that follow are based largely on participants' answers to 2 main questions. First, since the start of lockdown, did you use any of the following sexual or reproductive health services? And second, since the start of lockdown, were there any sexual or reproductive health services which you tried to use but couldn't? And participants were able to select all that apply. First, I'm going to show you overall service access in those aged 18 to 44 who were sexually experienced, and this gives a sense of the picture overall. Most people in the sample had not needed services during these 4 months, corresponding to just over 80% of men and just under 80% of women. However, about 1 in 5 people said that they had needed services. The slide here highlights the inclusion of trans men and trans women, which continues throughout these slides even when not mentioned. Overall, about 5% of men and 10% of women said that they had needed and been able to access sexual or reproductive health services, while 10% in both genders reported being unable to access the services at least once, and a further 2% said that they had needed services but hadn't tried to access them. Importantly, among those reporting at least one failed attempt to access a service, around 3/4, the 77.1% here, told us that they had also been able to access a service at least once. This was often, but not always, the same service, suggesting that many of those who failed to get a service also got to the service that they needed. That meant overall that just over 1 in 5 people aged 18 to 44 had accessed at least one sexual or reproductive health service in the 4 months from the 23rd of March 2020. Of this 20%, about half, so 9.9% of the population overall, reported that the service use was contraception services, and a quarter, 5% in the population overall, was STI-related services, and other services made up the rest. As you might expect, access to services varied substantially by age and gender, with women aged 18 to 29 being most likely to report accessing a service, and that was about 1 in 3 in this group, while among men, service use fell by age from a high of just under 30% in those aged 18 to 24. On the other hand, 10% of people in the sample aged 18 to 44 years said that they had tried but failed to access at least one sexual or reproductive health service. Again, this varied by age, with younger people most likely to report failing to access a service. Putting these side by side, you can see that failing to access services was about half as common in the sample as reporting successful access. The next slides focus on contraception services, and this is in initially sexually active and then sexually experienced women aged 18 to 44. To give you some context, the table here shows reported methods of contraception among women who reported having sex in the period since lockdown. Contraception was not applicable for about 1 in 5 women, and these were either trying to get pregnant, not able to get pregnant, or hadn't had sex, while just over 45% were using an effective method. Just under 1/4 of women were using condoms, and around 1 in 5, that's 19.8% shown in the bracket, reported either a less effective method, using emergency contraception, another method, or no method at all. Successful access to contraception services was highest amongst women aged 18 to 29, and that was at over 20%, while less than 5% of women reported trying and failing to access contraceptive services at least once, and this did not vary substantially by age. This slide is a forest plot which shows the characteristics of women reporting access to contraception services using age-adjusted odds ratios, with successful access on the left and at least one failed attempt shown as a forest plot on the right. As I've already mentioned, younger women were much more likely to report accessing contraception services, but there was no association by age for failing to access the services. However, women who reported being at a risk of a pregnancy were both much more likely to report successful access to services and also, with an even stronger association, were more likely to report needing but failing to access a service, shown here in blue. We also looked at 3 rarer outcomes in women: cervical cancer screening in all women aged 24 to 59, abortion or termination of pregnancy in sexually experienced women aged 18 to 44, and use of sexual assault services or rape services in all women aged 18 to 44. The numbers here are small, which means additional caution is needed in their interpretation. However, we found just over 2% of women reported uptake of cervical cancer screening, and just under 2% reported that they had tried but failed to access cervical cancer screening. Importantly, most of those who tried and failed hadn't also succeeded to access cervical cancer screening. This compares to an estimated coverage of the cervical cancer screening program in the same age group in a normal period of 4 months outside of pandemic times of around 6%. Small proportions, less than 1% in each case, reported needing termination services or sexual assault services, and less than 0.5% reported at least one failed attempt to access one of these services. The proportions here are small, but still indicate an important absolute number of women in the population who needed these critical services during this period and sometimes couldn't get them. I'm going to finish by showing data on STI-related services amongst people who were sexually active. 5% of those aged 18 to 44 reported accessing any STI-related service, and that included STI testing, STI follow-up care, and HIV testing. This was predominantly gum clinics or primary care STI testing and other services, with a smaller proportion reporting private or other services. The proportion reporting access to STI-related services was highest in the youngest men and women. Among the men, over a third reported same-sex behaviours, and the difference that you see between men and women is probably at least partly explained by the relatively higher proportion than expected of non-heterosexual participants in the Natsal-COVID sample. And reporting a failed attempt to access STI-related services was a bit less than half as common as reporting successful access. Aside from the age association, which was dramatic for both successful and a failed attempt to access STI-related services, it was noteworthy that gay and bisexual men were much more likely than heterosexual men to report accessing a clinic, but there wasn't the same association for women. And a range of behavioural markers of increased STI risk was strongly associated with reporting successful access to services. Here, the numbers in boxes refer to the proportion in the sample who reported each of these behaviours. And overall, the data suggests that services were reaching many of those who are at high risk. That said, we also observed that over 60% of the sexually active men and women who reported a new condomless partner since lockdown had not accessed STI-related services. Moreover, there were similar associations for reporting a failed attempt to access services, highlighting that unmet needs were associated with higher STI risks in the population, albeit that we would expect unmet need to be reported in the population even outside of pandemic times. Overall, these data suggest that services were reaching many of those in need, but at the same time there was unmet need and a sizable fraction of the population at risk hadn't been able to access services. We know that many STI services transitioned very rapidly away from face-to-face consultations. And amongst the participants of Natsal-COVID who reported service access, only 35 to 45% had done so face-to-face, while just under a third had used the telephone and around 10% had used a video online service. Another third had used an alternative online method. So overall, around 1 in 5 people reported accessing sexual or reproductive health services in the 4 months after lockdown. And this was most common in young people and in those with higher risk behaviours. At the same time, around 1 in 10 people reported trying but failing to access at least one sexual or reproductive health service. Importantly, many but not all had also succeeded. There was substantial reporting of use of online and telephone STI services, but video consultations overall were less common. And I should note that we lack baseline comparison data for service access and unmet need prior to lockdown. So what? What does this all mean for our services? Well, these data are consistent with the anecdotal reports that SRH services moved incredibly swiftly to enable access for many of those who were most in need during lockdown. But they also indicate that a sizable fraction of the population had trouble accessing services. And contraception and STI screening services may need to address a backlog of need amongst some groups at high risk, particularly among young people. These data provide important context to interpret the surveillance data that will come out for this very unusual period. And finally, I think it's important to highlight that there's a cohort of women who may have missed cervical cancer screening due to the pandemic, and these may need additional follow-up.
That's all from us. Thank you so much for listening, and well done for making it this far. I know we've presented a lot of data, but hopefully some of it will be useful for your practice, or at least provided some food for thought. This was a really huge team effort, and I wanted to thank everyone involved. In particular, Ipsos MORI, thank you to Margaret Blake and Ruben Balfour for their professionalism in working with us to produce the study. The survey team was large, but I'd like to single out in particular Swazi Clifton, who is currently on maternity leave and we're sad she couldn't join us today, but she was instrumental in the complex work of putting the questionnaire design together. It was not easy to get funding for this study, and in the end we had to cobble together money from various sources. We're very thankful to the UCL COVID Rapid Response Fund, to the MRC and CSO Social and Public Health Sciences Unit core funding, and also to our Natsal-COVID funders, the Wellcome Trust, ESRC and NIHR, whose money together enabled us to conduct the study. So we look forward to taking your questions. Thank you very much.